Welcome to Optima Healthcare Insurance Services webinar, Fire Preparedness and Lessons Learned from Critical Access Hospitals. I'm Haley Flower with Optima and today's program moderator. This webinar is being recorded. Everyone who is registered will get a link to the recording via the email address you provided. And as always, the handouts are available on our website at optimahealthcare.com. During the webinar, if you have any questions, please feel free to use the Q&A feature, and we will address all the questions at the end of the presentations during the Q&A session. We are lucky enough to have two of our owner hospitals here with us today to speak about their experiences with the 2020 and 2022 wildfire seasons in Northern California, specifically the Loyalton and McKinney fires. This June gloom weather, at least in Southern California, has me forgetting about fire season. But as we gear up for summer, now's a great time to talk about and be thinking about fire preparedness and response. Doug McCoy and his team are joining us from Eastern Plumas Healthcare in Portola, California. Doug has been the Chief Executive Officer at Eastern Plumas since May 2020. And lucky for him, he got to jump right into fire season. He has over 25 years of multi-facility hospital and skilled nursing facility management experience in 10 different states, with his background ranging from clinical to management development to human resources. In his role as CEO, Doug also oversees risk management, claims, and compliance. Joining Doug from Eastern Plumas, we have Dee Dee Clark, the safety officer, and Stan Pyler, director of operations. We will also be hearing from Sharon Carlucci joining us from Fairchild Medical Center in Yreka, California. Sharon has been an RN since 2006, working at the bedside in acute care for most of her career in a variety of inpatient settings, as well as in the emergency department, and has held multiple supervisory positions. She started her risk management journey in 2018 at Fairchild Medical Center and is currently studying for her CPHRM. So with that, welcome to all of our speakers, and Doug, you can go ahead and take it away.
Well, good morning, everyone. As Haley said, my name is Doug McCoy, and I'm very pleased to present on behalf of Eastern Plumas Healthcare. I have Dee Dee to my right and Stan to my left, and we are very happy to be able to share the experiences that we had and some lessons learned from the Loyalton fire, which occurred in August of 2020. A little bit of background on EPHC as I manipulate our slides. Eastern Plumas Healthcare is a district hospital in Eastern Plumas County. We serve the medical needs of both Eastern Plumas County and Sierra County. We are a 9-bed critical access hospital here in our Portola campus, which includes emergency services. We do have our own EMS department, so we run 5 to 6 ambulance rigs over the area in our district. Included in our hospital system are 2 skilled nursing facilities. We have a hospital-based SNF in Portola, and then we have a freestanding skilled nursing facility in Loyalton, which was the location of the fire in 2020. We also run 3 medical clinics, both in Loyalton, Portola, and Grayville. And we have 250 to 260 employees in our area, so we're the largest provider of services here in the eastern part of our county. As Haley said, I came on board in May of 2020, and in 35 years in healthcare, this actually was my first evacuation event. So like many of you, we have gone through tabletop exercises, we've gone through community drills, but the reality of actually being faced with the decision on evacuating a campus and then making sure that that was done in a safe way was certainly something new in my career. The Loyalton fire, and this was actually a picture that I took out of my car window on the very edge of Loyalton. Loyalton is a small community of about 750 residents. And so this picture was taken on the edge of town where the fire was initially started due to a lightning strike. With the amount of fires that we have all seen in Northern California over the course of the last couple of years, this would not be a real foreboding picture to be dealing with. However, the fire in the course of 48 to 72 hours became a much different situation. So this was on Friday afternoon when the lightning had struck the area. By the next day, the fire had intensified significantly. This top photo would be shown looking towards the Loyalton area. It had engulfed most of the hillside and then actually came over the hillside and headed towards the North Reno area and was going away in multiple directions from the Loyalton city itself. One of the first times that I had ever heard the word firenado occurred in the Loyalton fire. And as you can see, there were fire tornadoes that were occurring as a result of the fire. So the predictability and pattern of the fire was very difficult to calculate. Overall, it burned over 35 structures and 47,000 acres. And as I said, it had covered a large amount of ground just within a 48 to 72 hour period of time. By that Monday, the fire unfortunately had turned itself back towards the city of Loyalton, and we were presented with some challenges on what the next steps were going to be to maintain the safety of our patients. So a little bit about our planning. As I said, the fire started on the 14th, and by Sunday it had turned back towards the city of Loyalton. Dee Dee, as our safety officer, was monitoring both with law enforcement, CAL FIRE, and community agencies what the status of the fire direction was going. It redirected itself back to Loyalton on the 16th. We activated our HICS program on the 17th and began in the early morning hours starting to discuss, as the threat was intensifying to Loyalton, what our planning would be. And we held meetings throughout the day. I think that was critical for us because, again, at the time over the weekend, these issues always tend to happen on weekends or evenings. The fire was not heading in our direction, so it was heading away from us, but that changed significantly. So having those meetings was really helpful to begin our preparations. Some of the outlying areas, again, this is a rural community, some of the outlying areas were already in mandatory evacuations, and many of our staff members in the Loyalton area that work at our skilled nursing facility were having to deal with their own personal evacuations at the time. Towards the later part of the day, we decided as an incident command team to actually evacuate the building for several reasons. The imminent threat obviously was the key, but also there was the issue about being able to access the community based on the fire pattern, and then also be able to deploy our resources necessary to be able to evacuate the 27 residents that we had at the skilled nursing facility at the time. So mobilization of all of our resources to evacuate those 27 residents began about 8 p.m. And we were very pleased and very proud that we were able to get all of our residents evacuated within 90 minutes. This was an internal evacuation. Luckily for us, we had the capacity to be able to accept those residents at our Portola campus. But that also included the relocation of all of the patient-specific equipment within a 3-hour period of time. So some of the, so I'm going to turn it over to Dee Dee to talk about communication. Obviously, communication resource allocation was critical for us, and as our safety officer, she really took the lead in handling our incident command, and I would like to share some of her information.
Hi, good morning, everybody. Dee Dee Clark, Safety Officer for Eastern Plumas Healthcare. Thanks for having us join you guys this morning. We're glad to be here and be able to share some of our experiences and lessons learned with the Loyalton fire. I guess our main thing is we have the luxury of time on our side when this event happened. We were able to monitor it and do pre-planning for the event as it unfolded. As you can see, we live in a very rural, small community. We also have the luxury of being able to work with outside agencies very closely. The Sheriff Department in Sierra County, which is the county that the Loyalton fire took place, lives actually right down the street from me, and I know him on a personal level. So we were able to communicate directly via cell phone with each other regarding some of the issues that were unfolding as the fire took place. Also, we work very closely with public health in both counties, Plumas and Sierra, on a personal level as well. So having those close connections and open communications with outside agencies in our area played a vital role in being able to safely navigate through the event. One of the, recruitment of staff and resources. So we were able to plan ahead in regards to the possibility of having to relocate the residents in Sierra County at the Loyalton campus. And we also, as Doug mentioned, were able to do an internal evacuation. So some of the items that we didn't have to really consider were having to relocate our residents at other facilities. If that were the case, we would have accessed our local MOAC to be able to place those residents in other counties, other facilities outside of our area. We also were able to plan for the needs of our residents, knowing that we were going to do an internal evacuation. So we were able to pre-plan using the knowledge of the residents in regards to who was ambulatory, who needed to be transported via ambulance, and then also our residents that were able to return to their families. We had a couple of residents that we went ahead and moved home prior to being able to evacuate the location. So we have 29 residents, but 2 of them went home. And then we were able to plan in order according to acuity on how we were going to move the residents via ambulance or outside vehicles. We also were able to plan for the acceptance of the residents at the Portola campus, and which rooms being able to relocate current residents in Portola to accommodate the Loyalton residents. We are also able to pre-plan the evacuation of equipment, wheelchairs, beds, tables. We have specialty mattresses, Hoyer lifts, those type of items as well. We also worked very closely with physician oversight in being able to pre-plan for medical supplies, medications, tube feedings, and then also work with our dietary department in regards to making sure that we had the appropriate staffing and resources and food available to accommodate the 27 residents that were brought over to the Portola campus. Again, pre-planning again for the tracking of the residents, their belongings, the equipment, the supplies, stuff like that. We actually, one of the things that worked well for us is we had go bags for each of the residents that we prepared in advance, that we learned from one of our countywide drills, that we were able to pack a personal item, clothing for a couple of days, their paper charts for medications and items like that. We were also able to move our med carts in whole with the help of facilities in their pre-planning. So we had, specific medications per residence. And then we also were able to start the planning process in advance from having them relocated to the Portola campus on a short-term basis, and then started the pre-planning process of what if we have to keep them there for long-term, starting to look at maybe transferring out to other facilities, that type of thing, with the utilization, working with public health and our MOAC.
I think a couple of other things to add that were in our favor, along with the internal transport between campuses, was the fact that our resident acuity was fairly low. So for facilities, if we were a facility that, for example, had skilled nursing patients on ventilators or with various infectious disease issues for cohorting reasons, that would have been much more challenging for us. And so I think that is one of the areas that we would look at is as our acuity is changing, so will be the needs for any type of disaster management, both in transportation, but also cohorting equipment, etc.
So talking about the transportation of the 27 residents, we have a facility-owned ambulance service. So some of our non-ambulatory residents were able to be moved via ambulance. we called in a couple of extra crews and were able to move the non-ambulatory residents fairly quickly without incident. Also working closely with some of our the outside agencies, the next closest ambulance service was about 40 miles away, and they were able to provide backup for us while ambulances were in service being moved by moving the residents internally. One of the lessons learned was that we have an MOU with our local school district, being able to utilize their drivers and their vehicles during a disaster. And one of the things that we learned, unfortunately, was the drivers that they had in Sierra County were also evacuating and unavailable to drive the buses. So by the time they were able to mobilize and get a driver to the school campus, get the bus going, we had already completed our evacuation internally, utilizing our patient transport van, our ambulance service, and then a couple of our own private vehicles to make the move successful. And also we found out that that utilizing the personal vehicles, not optimum, but the acuity of our residents, we were able to do that safely. Stan and his team played a very critical role. They worked closely with the town of Portola, city of Portola, on a very close basis to be able to utilize their staff and some of their equipment in regards to the evacuation. So Stan, if you want to talk about some of your planning that went on with that.
Yeah, thank you. So thank you for having us. My name is Stan Heiler, Director of Operations. So the responsibility that I was tasked with was to make sure that all the beds and all the residents' equipment was being able to be transported from Loyalton to Portola. In doing so, we have a great relationship with our city here, and we work closely with the Director of Public Works. They were able to bring out 3 or 4 trucks with heavy duty trailer beds. We also, as engineering, brought all our trucks and trailers. And we had numerous people helping us. So I guess where it all started too is it started with EBS, housekeeping. So they prepared all the beds, they tagged all the beds with the residents' names. They made sure that they stripped the beds and everything was disinfected prior to bringing it over to the other Portola. Once we got it all loaded up and we were able to transport everything over to Portola, there was EBS crew there and everybody was there to help unload and get everything, all the beds made and so forth. If I could share, one of the things that was important for us was to make sure that our disaster linen was accounted for. As we're bringing over all of these new equipment, our Portola facility only had enough for the residents that live here. So that played a vital role as well. It was a good experience. One thing that I guess I might add is that in that experience, we had so many staff member and family people just came to help. So I look back at what we might be able to do better. The lead or the key staff players, I would recommend that they wear a yellow vest or a red vest, and then they carry radios. During that event, if we had that, people that don't know our facility or are here just to support are looking for guidance. And so it would be ideal for them to find someone who's in a vest, and then we could radio back and forth so that we get the full help that's there and not have confusion.
Okay. And I would just like to add to that, as Dee Dee mentioned, the school buses, the drivers, and many of our staff were dealing with their own evacuation. But part of the reason that we also made the decision on the timing of the evacuation was we knew the later we got into the night, the chances of being able to have some of these additional community personnel available to us would decrease. So making the decision earlier, I think, was to our benefit in order to be able to get all this equipment and get the equipment moved location to location. So we'll talk a little bit about internal communication.
Yeah, so a couple of the areas where we identified there was room for improvement and some gaps that we came across was, unfortunately, we did not activate our labor pool in time. We were focused on evacuating the residents. And so, not that it became a problem, but we had a lot of staff who responded to the Loyalton campus from notifications that were being posted on social media. Instead of being able to pull from a labor pool like we should have and have them on standby and be prepared to move. Thankfully, we are a small community and everybody responded appropriately. We had enough staff that showed up on site to effectively move the residents and equipment in a timely fashion. So activating your labor pool and having someone oversee that early would be highly recommended. And then also one of the things that kind of got lost in the shuffle was making sure that the medical provider who oversaw the Loyalty campus was actually involved in hands-on the relocation of the residents. She was notified after the fact, the following morning, and she felt that it would have been imperative for her to be there to make sure and oversee that all the medications and prep work, such as tube feedings and IV antibiotics and stuff like that, were prepared and ready to go with the residents that needed them. And then also we found that more incident command training for the upper management level was important to identify roles and responsibilities for assigned tasks. Some of our upper management was not aware exactly what their roles were and where they came into the picture to help us. So we did some online training through FEMA that helped the staff know exactly what their role and when they were to be activated to take control of a certain area in regards to the facility evacuation. And so trying to handle too much is kind of what I did in regards to not assigning certain tasks to other staff members to handle. I tried to take on too much all by myself. So one of the lessons learned for myself is to really utilize the availability, the expertise and knowledge of the people who are available to help and assign those tasks and kind of lighten my plate a little bit. And then internal evacuations versus external.
Yeah, so basically, I want to make sure we give some time for Sharon. So looking at our gap analysis, making sure that we have some secondary options. Our district hospitals in our county are very small like we are. So bed availability will be challenging if we would have to go outside of our own internal network. Staff sharing with external agencies, again, as Stan said, without the help of the city and their flatbed trucks for equipment moving, we would not have had the resources to be able to do that. So making sure that those relationships are in place. And then also, again, looking at expanded transportation needs outside of our MOU. Some recommendations that we would have for the group that's participating today. First question would be, can all of your patients, residents, et cetera, be relocated internally or to just one location? That made the difference for us. Had it been multiple locations, our time would not have been 90 minutes. It would have been several hours. And if it's a large scale event, beds may not be available. Again, we talked about the school buses. If primary resources aren't available, do you have a secondary in place? It was very helpful in the Dixie fire, and we learned this from the Loyalton fire, to have one representative that was monitoring the fire activity on an hour-to-hour basis of reporting back. That was very helpful. So there was one clear, consistent message that was coming from all the various agencies. Fire ground speeds were reported in our recent fires at over 20 miles an hour. So the chance of course changes literally is occurring hourly, and that helped us to stay on top of it. I don't think we were prepared for the volume of or a volume of external patient family calls. So making sure that there is a large enough group to field the incoming calls that families are having, because that was a large volume that we were receiving in. Equipment transportation, as we said, looking back was probably something we didn't speak about, and we were lucky that Stan and his team had the resources available, but we would not have had the equipment available in our receiving location. So if you require equipment moves, we would really recommend looking at that. The patient backpacks or go bags were very, very helpful for us to make sure that all residents had the items that they needed and supplies. One thing, again, that I did not realize is you will need to have CDPH, HCI, OSHPD approval to relocate back into your facility. We were lucky that they were able to do that for us within 48 hours, but if there are delays on the state side, that will then delay your ability to return back. They will not allow you to return until they've actually done an on-site inspection. Looking at your IT resources, again, we were lucky it was internal. Access to EMR data was very helpful for our physicians to be able to provide continuity of care, but if it's outside that system, your own network, that would be something to take a look at. And I think as Stan had mentioned, we were now doubling the amount of residents that we had in one location. Do we have enough medical supplies, the pharmaceutical needs, food, etc.? Certainly everyone has emergency food supplies. However, this is a different situation, especially if you're going multiple days in. The other area was security of the evacuated location. We had a staff member that remained on site. However, that presents some challenges if you have a vacated building, and I think we would put a little bit more focus on that if it was going to be a long-term issue. And then staff support and recognition, both during and post-event, I think was very helpful for us. So we really appreciate the time, and we'd like to hand it over to Sharon. And thank you so much.
Thank you.
Thank you.
Okay, hello. And thank you, Doug, and your team. That was a great presentation. My name is Sharon Carlucci. I am Risk Management and Patient Safety Coordinator for Fairchild Medical Center. We are a 25-bed critical access hospital. Trying to get my slides to advance. It's going to take a minute here. We are located in Siskiyou County. We are the county seat. Wairika is. We have a population of about 7,800 residents. And on the end of July in 2022, we were faced with the challenge of the McKinney fire. So see if I can advance. Just going to take a minute for the slides to catch up here. So in July of 2022, our region was in a severe drought, extreme drought, actually, according to the U.S. Drought Monitor and National Drought Mitigation Center. Our particular area also was in a heat dome, which means that our temperatures were consistently above 95 degrees and hit triple digits several times in the 2 weeks leading up to the McKinney fire. So, hey, there we go. There. So you can see our town here. We're in a mountainous area, which poses its own challenges. You can see Wairika kind of is horseshoed by this kind of mountainous area. And along Route 96, that's right where the fire started. So we had a couple of ridge lines between us initially when it started. Kind of afterwards, when they looked at the footprint of the McKinney fire, they noticed that much of the area had not burned since 2014, and some of that area had not burned since 1955. So lots of dry fuels and, again, mountainous terrain to pose problems. So here's our facility. On top is the top picture is our hospital. You can see our services listed out. Like I said, we're a 25-bed critical access hospital. And then right across the street, we have an outpatient clinic. This happened on the weekend. So we do have an express care in our clinic, which was open during the time. We also have 3 offsite outpatient clinics, but they were closed due to the weekend hours. So we have approximately, including providers, 650 employees, and about 215 of them reside in the town of Wairika, which was largely evacuated, as you will see. So on Friday, July 29th, 2:15-ish, In the afternoon, there was a 40-acre wildfire reported. That night, the winds were strong. We had surrounding thunderstorms in the area. And by early morning, Saturday, that fire had grown to 18,000 acres. And the winds were still strong, and it was blowing it right towards the town of Wairika. By the night of the 30th, kind of late afternoon, early evening-ish, the winds really kicked up. They lost all containment. And overnight, from the 30th into the 31st, that fire grew to 51,000 acres. You can see the total burned was 60,000, and you can see the structures and the fatalities. So a lot of structures destroyed. Only 4 fatalities, which was good, and minimal injuries. So I kind of want to note here too that this fire was being managed by the Klamath National Forest Service. And I think by day 1 or day 2, they had invited CAL FIRE in and was able to work together to really expand their resources. So this is the pyrocumulonimbus cloud. It's not as impressive as the fire NATO, but it did create its own weather. Of course, this is always a challenge. In this case, it actually created its own electrical storm. So not only did it kind of skew the winds and made its own wind, it created its own lightning. So, you know, fire likes to feed fire. So just to be clear, we never were fully evacuated. The hospital itself was never in a mandatory evacuation zone. So, but we did perform precautionary transfers of admitted patients and patients in the ER that required admission. Our acute care services still were available if need be, including, you know, we have an OB department, so we were able to do OB checks if needed to stabilize and get them out where they needed to go. Evacuation is risky, of course, and then as the Eastern Plumas team noted, you have to have permissions to return back into your facility. So we were fortunate there that we didn't actually have to evacuate. So before we kind of dive in, you know, I just want to take a moment to look at our logistical concerns. We are, you know, a small rural community. We have very limited resources with our transportation or medical transportation. So we have 1 ALS crew available, 1 BLS crew available. We do not have our own EMS services, so we use Sierra Sacramento Valley services. So, you know, if you're looking at critical care transports and you have a BLS crew, you're going to have to send a nurse, which causes problems with staffing. You know, we were able to pull from South County an ambulance crew and then another ambulance crew from Fort Jones area. So in addition to that, many of our staff were evacuated from their homes. You know, we have a small engineering staff. Engineering is extremely critical when you are looking at evacuating. We have a 4-man team, and 2 of them were evacuated from their homes. So kind of trying to make accommodations for them and having them kind of rotate through on shifts was really essential. Our goal, really what you need is 2 engineers on at all times during a situation like this. So the other challenge was many staff are partners or married to first responders, fire department, you know, EMS, law enforcement, and other healthcare essential workers. So, you know, they have families and kind of limited our labor pool, really. So here's kind of the timeline of Saturday when it all started. Excuse me, our disaster coordinator received a phone call from public health regarding the fire, saying to be on alert. She escalated that up to our chief nursing officer, and a decision was made to call on the incident command. So as you can see, the incident command arrived about, you know, 12:18, 12:20, and within 20 minutes, we received another call saying, you know, this fire has really kicked loose and picked up. And then we were sort of recommended to do precautionary transfers by public health in conjunction with the EMS agency. So at that point, we contacted Mohawk, who started to find beds and transport mostly within the state of California. And then also on our end, we started contacting our regional hospitals up in Oregon that we work with frequently to try and just start finding beds for everybody. So as you can see, there was no diversion at all. we kept our ED open and we started preparing the patients. We started making their med bags and started printing their transfer packets. So we do have an auxiliary wheelchair van available. So that was very useful for us. We definitely use that. We had some issues, Mercy flights, you can see they were kind of limited. On top of that, there's smoke and thunderstorms to deal with. So that really decreases their visibility and sort of ties their hands a little bit. So around 1 o'clock, we did a sweep in urgent care. We decided to send those patients to the emergency department for evaluation. And at that point, a decision was made to shelter in place. And as you can see, just kind of another discussion happening about logistics and equipment, and making sure that, we have all our supplies that we would need. And then we sent the public information officer over to the County Emergencies Operations Center to their incident command, just to shore up that communication. So. We got another call. The Chief Lemos from the Wairika Fire said, you guys really need to be ready to go. We had already created some transfer plans for a lot of our patients. At this point, we closed express care, like definitely evacuated the clinic. Engineering went and did a walkthrough. Actually did find someone in there working on charting on the weekend. So it was a good thing they did that. And we just continued to prep our patients to go. You can see here, really the timeline here is just to demonstrate, we are finding beds. A lot of times we will lose the bed, then we have to find other beds. So, Mohawk was a great resource. They sent the Sierra Sacramento EMS director directly to us, and they were able to coordinate transfers. So they actually sent us 3 ambulance crews from St. Elizabeth's Hospital, which is down in Red Bluff, about 2 hours away. And we were really able to start getting our patients moved out. This is just to demonstrate that at a certain point, our clinic did meet criteria to be in a mandatory evacuation zone. So that actually officially happened around, I think 6 or 7 o'clock that evening. We had already did a precautionary evacuation of the clinic. So nobody was over there, but it kind of comes into play later on during our recovery phase. And this is just a picture of the evac zone. So in the Be Ready zone, that's where the hospital is. Luckily, I-5 remained open and Main Street for the most part remained open, so that we were able to transport and keep people moving. So, but you can see we were kind of horseshoed and just surrounded by mandatory evacuation zones. So some of the public perception was that we did that on purpose, that we had something to do with that, but we did not. And that's just kind of the way the cookie crumbled, so to speak. So again, we're dealing with finding beds, confirming beds. We can take 3 patients. Oh, we lost a couple beds here and there, just to show that there's a lot that goes into transferring patients off-site. You can see down at the bottom, we had a transfer delayed. We had an ED patient whose transfer was set up to go to San Juan, which is pretty far away from our town. That transfer was set to happen prior to the fire and the precautionary transfers. So that posed quite a challenge. We could not really move him by ground. It would take too long and we needed all our resources on hand. So eventually we did find a way. We transferred by ground up to Medford, where they put him on a fixed wing, and got him to San Juan. So again, just more, kind of timeline stuff. We're updating the county. I actually had gone over to replace the public information officer over at the county incident command. I recommend having somebody there just for the communication. I think the last presentation said that as well. It just communication, having real-time updates on the fire was so helpful and so important. And then also another piece of that was there was a public health worker there at incident command, and I was in direct communication with her so we could keep track of our patients that we were moving, where they were going, and how they were getting there. So again, engineering did another sweep through of the clinic after the official mandatory evac went through. Nobody was there this time, so that was good. We kept having to reconfirm that our emergency department was not on diversion. There was a lot of miscommunication. I think you have to be careful with your verbiage. It's really easy to say like, hey, we're going to evacuate the hospital, but that really has a larger meaning, especially to staff. So if you kind of put it like, we're just doing transfers, precautionary transfers, because right now we have time. And so we want to make sure that we're just proactive about this. I think that would have helped us out a lot. There was a lot of confusion about Fairchild being evacuated, our ED being on diversion. There were things posted on social media, which we had to go and correct. So, you know, just kind of challenges with communication and the message that you're sending out to your community. While I was over at the incident command in the county, they started talking about diverting some of the resources off to a smaller fire that had started. So in my mind, that kind of prompted the question, does this affect our ability to shelter in place? We had a shelter in place plan, you know, where they would come and create a defensible space around the hospital. So I was able to pose that question directly to, you know, the authorities, and they said, no, this would not affect it. Basically, that defensible space would be held by your local fire department. And so, you know, all was well, and we could continue with our shelter in place plan. Meanwhile, engineering is starting to do their walkthroughs, their what we've lovingly nicknamed the abandoned ship process. So they have to look at their medical gases and their oxygen. You know, they are the last to leave the building. If you were to evacuate, you have 2 engineers, and they are the last people to leave. So they were going through, walking through their plans and making sure that they knew exactly where to go. So, oh yeah, and then our on-call obstetrics and pediatrics doctor, they happened to be married. They were also evacuated from their home, so they were temporarily unavailable for that evening. And then there's this. So thanks to the COVID pandemic, we had to expand our oxygen supply. So in the meantime, we have 80,000 pounds of liquid oxygen in our back parking lot. So this was brought up during our shelter in place discussion and plan with the fire chief. And they basically said, you have to contact the vendor and see what you can do to mitigate it. I mean, it is what it is. We can't move it at this point. It's going to be there. So it turned out that this particular setup has like a pressure release valve. So instead of, you know, exploding, it would just actually release the pressure and release a lot of oxygen, which is still an accelerant, but I think it's better than having a bomb in your parking lot. So, so around this time, you can see we're still, you know, communicating, we're keeping track of when our patients can go and where they're going to go. Around this time though, about 2030, they closed the incident command at the county. So I was sent back, I reported back to incident command at the hospital. And then I basically held down incident command on the night shift. So the problem with that was all the communication stopped. So during that night, I didn't have any updates on, they have like a safe haven zone map app that you can have on your phone. There are no updates happening there. I really wasn't getting any updates from anywhere else. So I found a scanner app on my phone, and I basically walked around the perimeter of the hospital looking at ridge lines and making sure that nothing was coming over those ridge lines. So I did also have the med surg and OB manager with me. So that was helpful too. I wasn't just by myself, and the rest of our incident command were still on the property. They were staying in empty patient rooms. So I had access to them, but still that was a little bit of a dicey night. It made me a little bit nervous, hoping I don't have to do that again. And this is just a list of basically all of our patients. So in total, we had 16 patients. We were able to discharge 1. That was kind of one of the things. We had patients on med surg, and we thought, well, maybe we can get some of them home, you know, kind of early discharge. Well, there's no such thing as an early discharge. If people need to be in the hospital, they need to be in the hospital. We were able to discharge 1 person that was set to discharge that day, and she went home private vehicle with her family. But you can see we transferred to a total of 7 different hospitals in approximately 7 hours. So we felt pretty accomplished about that. It's not really an easy feat. This is our thank you slide. These are all the people that came to our rescue to help us and to get our patients moved and really helped us be proactive and get our patients out. So So late that night, we did have an OB check come in. As if you remember, our OB doc was evacuated, so that kind of took our whole service down. At the time, we were very short on OB providers. Our nurses are trained to do OB checks and medical screening exams for OB patients. So we were able to keep her. She stayed stable. She was also ambulatory, and we had a transport plan for her in case we needed to go. So just also, again, being proactive with that. So, certain things came up. We had people still coming into the ED. Many people did not have transportation home. So with our wheelchair van and with our facility vehicles, we were able to get them home. One particular woman, actually, we took her home. It turned out she was in an evacuation zone. And then, the engineer that took her home was trying to help to get her evacuated while her car was out of gas. So just kind of things that we ran into. So he was probably tied up with that situation for a good hour plus, getting her car full of gas, getting her where she needed to be and safe. So again, we're just continuing to update. We changed shift right around 5:30 or so and provided more updates. CDPH, the County to Public Health, reported to the CNO, and just still evaluating and reevaluating our situation. So the OB doc was able to arrive. Apparently, by that time, this patient was in active labor, and we got her up to Rogue. So the CEO, now we're into Sunday, right? So we're coming into Monday. So the CEO, there were a lot of discussions about our services. We canceled all of our offsite rehab appointments, all of our clinic appointments, elective surgeries were canceled. Our business services building was not in an evacuation zone, but we just said like only necessary staff, because there were things that were happening and they were having to scan in transfer paperwork and all sorts of things like that. So again, all pharmacies in the city were closed. It got to a point where basically the town was shut down. So not only are we dealing with our resources within the organization, the resources we depend on outside of the organization, including gas stations and things of that nature, are also shut down. So canceled patients for Monday into the clinic. That evening, we had a thunderstorm come through, which was a blessing. It rained hard and it rained fast. So we did have lightning strikes. We had small spot fires, but just the humidity and the rain really helped to suppress the fire. At one point, engineering was out there watering the lawns for our defensive space. We were told no, to stop that, because if it comes to town, they're going to need all those water resources. So then we were thinking, if we get cut off of water, what are we going to need to do to get potable water in? That was precautionary discussion. It never came to fruition, thank goodness. So we were okay there. Again, we still have business as usual. We have medical records that need to be scanned, and we have people doing payroll. So more essential staff duties. This is just a footprint of McKinney Fire. You can see the little building there is our hospital. You can see how close it was. At one point, they were estimating it to be about 4 to 5 miles as the crow flies from the town of Wairika. So the fire the night before really helped crews to be able to get out and get some good ground breaks in there and get some good dozer lines and fire breaks. And if you're ever in Wairika in the wintertime and you look up on the hills, you can see, especially after it snows, all the lines. I mean, the whole town is surrounded by these dozer lines. So it was a huge effort. They did a great job. So then by the 1st, we were feeling a little more secure. This was Monday. Of course, we had the rainfall, like I said. We had some other logistical issues. Our hospitalists come from out of state typically, or far away in the state. We typically fly them in and have them come to pull their shifts. Well, with thunderstorms and the evacuation and the fire, we had some issues getting them in. So our chief medical officer just assumed the hospitalist role, which really, we didn't have a lot of patients. We weren't taking admits at that time. So we just continuous evaluation and reevaluation of our situation. The fire was about 30% contained, but we know that can change on a dime. Also, the clinic was still in a mandatory evacuation zone. So there were concerns regarding, patients kind of flooding and overwhelming our ER. And so right around that Monday or Tuesday, discussion started with our CEO and senior admin with the fire authorities to see if we could get them to rezone the clinic to match the hospital into just a be ready zone. So that was successful. And on the 3rd of August, we were able to open up our express care, which helps take the heat off the ED a lot. And then Thursday and Friday of that week, we started to kind of take soft admits like low acuity, definitely had a plan, easy to move. And then we pretty much reopened everything on the 8th. We were pretty much business as usual. So in the interest of time, we're going to kind of skip. That's just more fire perimeter here. So accomplishments, we can actually do this. We also had great support from our Sierra Sacramento Valley EMS agency. Mohawk really came through and got those resources to us. Our communication with CDPH was great. And with our local public health, again, just good communication, keeping those point people on so we get accurate information relayed. So, oh yeah, the EMS crews actually were evacuated, so we had them staying at our hospital as well, which kind of worked out okay because then they're right there for us. So staff members kind of came out and said, hey, people are evacuated, you can come stay at my house. So we kind of had some great teamwork there. Great interagency, interfacility transfers. Everybody works so well together. We had an auxiliary transport van that was being used to get patients up to where they needed to be. Basically, we would have an engineer in there driving because they had they were insured to drive the van, and then we would send a volunteer RN with them just to monitor the patients. We had visiting nurses services that remained open. So that had its own challenges with the evacuation zones. You have to figure out how you're going to get to your patients. So also it was fair time. And so our neighbors to the north said that they would host our fair essentially for us. So that was great. So a lot of great community getting together and helping out. So lessons learned, use your incident command paperwork so you don't have to transpose everything. Make sure that your incident command staff are familiar with it. We had an alternate care site that was 1 block over and it was still in an evacuation zone. So make sure you have multiple alternate care sites lined up. It's great to have them close, but sometimes that's also a drawback. The family plan prepared, for reuniting patients and their families. Also, I would kind of throw into that for your staff too. Make sure that your staff are in a place where their family are settled so that they can focus on what they need to do. It's extremely distracting to try and be involved in an incident command or a disaster when you're concerned about your family and how they're going to get out. So we have a mass messaging system called Informacast, and it really wasn't up to its full functionality. We only had about 100 staff members that were signed up on there. So that's something that we've been really pushing. And a lot of our staff don't access their work email from home, things of that nature. We also have a lot of off-the-grid community members, which poses a problem. We had community members calling EMS for transport to help them to evacuate, not really because they had any medical needs. We also had community members that are bedbound, but didn't need acute medical needs either. So make sure you have good communication with your shelter, the public health shelter, of what kind of patients that they can take. Because what happens is they end up kind of tying up your resources because they're in the ambulance. EMS doesn't know where to take them, and so it just causes sort of an issue with your resources there. Citizens will present to your parking lot, so make sure that you know where to send them to the public health shelter. We talked earlier about the misinformation spreading to social media, so just really be careful of your verbiage that you're using. We also were able to use some checklists, some of the California Hospital Association's hospital evacuation plan checklist. We were able to hand that off to a CRNA and some other staff members that, this is really outside of what they normally do. So they were able to follow those very easily and able to really assist us and be part of the team. Again, communication with local Office of Emergency Services, that's just very, very vital. We also had issues with roll call or tracking staff that were coming in and out. So we have to keep our front doors open. We can't lock those down, but we posted signs for staff, and we basically limited the staff entrances to one entrance that's right by the time clock and right by the boardroom, which was incident command. But we still got people that were coming in through the front and not registering in with incident command. So I think in the future, I would like maybe post somebody there just to direct them as they come in. Again, we talk about the defensible space and watering the lawns. Well, that was kind of shot down, so not a great plan, but that's okay. Take really good notes. You know, document your number of staff that are evacuated as well. The other thing we kind of are looking into is making our incident command more mobile and give more like functionality with it. So people do strange things. We had a traveler that was calling SSV saying, I don't feel safe to be here. People were calling the state, trying to say like, you need to go on diversion. We need to go on diversion. So just make sure that your communication is shored up and that your authorities and your agencies that you're dealing with know that they just talk to one person. So staff using extended sick leave versus PTO for the fire, you know, have that plan in place so that they are not surprised when they have to take time off for that, you know, whichever way you decide to do it is fine, but I would just make sure that they know. And trust your experts. For a minute, they were trying to make staffing decisions out of incident command. And really the house supervisors do that every day. So let them do what they do. Engineering is huge whenever you're dealing with a situation like this. So we have a wildfire smoke protocol where we reduce the outside air into the air handlers, and they replace the filters every so often. So we went through all 4 sets of our filters over 72 hours. So we had to wait another 2 weeks for those to be replaced. We made it work, but you know, maybe I think now we have more filters on hand. Insurance, make sure your engineers are on the vehicle insurance policies. We do have some EVS staff that are on there, but you know, your engineers are so precious in these situations. So, you know, make sure that you expand so that people can legally drive your vehicles. Fuel refill when possible. Like I said, you know, the city basically kind of closed down. Security, you know, security engineering and security are to control access to the facility. They talked about parking entrances to parking vehicles and entrances, but decided not to because of ingress egress deals. So, you know, just be mindful of that. There are looters that go out during certain incidences. I know that the police department was in full force during this time as well. So, and yeah, we use every vehicle to transport patients and to get ED patients to their homes. Shut-off valves, the Joint Commission asked for your supply valve map. Make sure that is up to date. That was critical for them as they walk through and practice their shutdown processes. You know, and have that a communication plan. Make sure that you have 2 designated engineers to do the final shutdown procedures. And just every shift they walked through and got familiar with it. So that was good. We had a couple new engineers on staff. So that was a good thing for them to do. Have phone numbers of important people on their cell phones, not just their office lines, right? And then just make sure that you are able to support your staff during this time because it's stressful and, you know, we have families to take care of and you're going to have to be flexible with your rotating your staff through. So that's the end of my presentation. I'd like to thank you for having me here today. It was so great to be able to share with you. Here's some contact information here. If you have any questions, please feel free to email us at those email addresses, or you can reach out to Haley directly. So thank you.
Thank you all for your great information. And I'm sorry that you had to go through it, but I'm grateful that you share your experiences for the rest of us as we maybe reevaluate our plans that we have in place based on this too. I don't see any questions that have come through for our attendees. If you have a question that you want to Q&A, and we can throw that to our speakers. In the meantime, Doug, Dee Dee, Stan, Sharon, thank you so much for taking the time to share your lessons learned and give us some good ideas to be thinking about. Really great presentation and valuable. I know it. Thank you all. I don't see any questions and we're at time, so I'll go ahead and call it. But thank you all for joining us, and thank you speakers. Please complete the online evaluation for the webinar so we can see your feedback, and have a great rest of your day.